Good morning. Can people hear? This is working, right? Great. Okay, welcome to today's session, Evaluating New Evidence, How to Evaluate It, and When to Use It. I think there are a few conference announcements that they want me to... No, we'll go with our intro. This is fine. So we have a couple objectives today. We're going to be using a case study format as a jumping off point to understand scientific validity and some concepts therein, and walk through some criteria to read and evaluate scientific literature about newly emerging strategies and innovations that address some MCH national performance measures and priority areas. And then from there, after we talk about how to evaluate evidence, we take the next step. Once we know how to evaluate it, what are some next steps to use that evidence about that innovation to support ongoing program efforts? So we address some considerations around implementing those strategies, and we hear one from Julie Prescott in particular on one specific Title V program with how to proceed and how to communicate that evidence to stakeholders. So after our intro, I'll turn it over to Dr. Michael Kogan, who's going to give an overview of the MCH and MCHB transformation and some of the strengthening the evidence programs. And then we move to Dr. Donna Sturbino, who's going to give some context on the case study of the baby box to address the NPM-5 for safe sleep. And then we'll hear from Julie Prescott on some of her experiences with the baby box in Alabama. Then after a quick break, we're going to talk about some concepts within scientific validity and how to evaluate literature and the strength of evidence. And then we'll use the study that we circulated, that BADIC study, on a baby basket in New Zealand, both in small and large group formats to actually evaluate that evidence and then decide what to do with it. So our speakers today, Dr. Michael Kogan is Director of Epidemiology and Research at the Maternal and Child Health Bureau. Dr. Donna Sturbino is Professor and Vice Chair of Education in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. Julie Prescott is an Associate Professor in the Department of Healthcare Organization and Policy at University of Alabama, Birmingham School of Public Health. And my name is Blair Berger. I'm a doctoral student in Donna's home department, Population, Family, and Reproductive Health at Hopkins as well. So just to gauge who's in the room this morning, how many of you are MCH directors or children with special health care needs directors? Got one back there? Hi. How many of you work with data or epidemiologists? Oh, tons. Cool. You're going to like this session. All right. How many are here representing government agencies at the federal level? Some? How about state level? More. And local level? Who's here from academic institutions? Anybody at other health programs that I didn't mention? Some others? Okay, good morning. So I'm going to turn this over to Michael Kogan now. Oh.
So before Michael,
yeah.
Why don't you tell them a little bit about yourself and what you do?
Sure. Sure. I do a lot of work in measurement for quality of care in maternal health in facility settings. I do that work internationally for my dissertation, and I also do some of that work on severe maternal morbidity and also some unintended pregnancy work in the state of Maryland with the state health department. That's the short answer. Yeah.
Good morning, everyone. I'm Michael Kogan, and actually, if you look at the previous slides, my middle initial is not K, it's D, like Mad Dog. And I'm the director of the Office of Epidemiology and Research at the Maternal and Child Health Bureau at HRSA. I was also the co-chair of the Performance Measure Workgroup Framework. And so Blair asked you a few getting to know you questions. Let me ask you a few more. How many of you have ever made a souffle? So not that many, okay, good. How many of you rooted for the New England Patriots in the Super Bowl? How many of you think you'll be over it by July? Okay. So Donna contacted me, since I worked on this for a few years, to give you a little bit of information about the MCA's transformation and the role of evidence in that. So I'm going to take about 10 minutes to talk about it. Oh, first, since we're on camera, does anybody mind that I'm not wearing a tie? Does anybody in this mostly room full of women have a tie I can borrow? No? Okay. Sorry. All right. Let me first begin by asking you more questions. What brought you to this workshop?
Curiosity.
Curiosity about what?
Curiosity about the topic in terms of evaluating new evidence and how to evaluate it.
Okay.
What was going to be presented is.
Okay, good. So curiosity about the role of evidence, and you had your hand up.
Yeah, I was just gonna pretty much say the same thing, that I'm always looking to push myself outside of my box, and I thought that this would be an opportunity to do that. Focus on evidence, because everything's shifted that way. And New Jersey has this whole safety sleep box thing going, so I also thought that the case study was interesting.
Great. So the case study was interesting, and you're curious about the topic. Other reasons, yes. You have a time for me, right?
Sorry, I live mine.
Do you want to borrow my sport coat? Great. What size are you? I take that as slim fit.
So in addition to wanting to assess new evidence, we wanted to see, well, if we can find out how to assess new evidence, that would give us some information on how to assess our own programs, to make it the next level of evidence-based program.
Great. Yes, so you also added on, in addition to everything else, how to assess new evidence. Other reasons for coming here? Okay, that's really good. So let me ask you a different kind of question. Why do you think there is such an evidence? Why do you think there is such an emphasis on evidence? Why do you think there's increased emphasis?
Limited budget?
Pardon?
Limited budget, so what you spend.
Limited budget, good. Let me call you back first.
Yeah, well, we spent lots of money into programs, and we want to know if they work.
Yes, less money for programs. We want to know if they work. Excellent. Diane.
Evidence can bring you to specific outcomes. We follow what's been established.
Yes, great. Evidence can bring you to accepted outcomes, the kind of outcomes you want. Other thoughts? Because this is really what was one of the driving forces behind what we did on the performance framework.
I think it's not about money, and also it's about time. We don't want to waste our investments.
Yes, great. Don't want to waste our investments, right?
Decision making helps make the better decision.
Yes, thank you. Decision making, spoken like a great manager.
The desire to actually see change.
Absolutely, great point. The desire to absolutely to see change. Other thoughts? Yes.
And this may be more of going along with why we're here as well. Stuff I did in my dissertation work was to figure out what do you do and how do you set public policy when evidence is missing or contradictory. And that's an important thing of evaluation, because you have two or three incredibly valuable, respected scientific bodies. The teenagers in Mortality said they've got all their receipts.
Yes.
But you've got all these things in order, but they're contradicting each other.
Yes.
And my job is to set public policy that somebody else has to follow. How do you do that?
Yes, great. So when you have evidence that sometimes contradict each other, how do you decide? The way I decide is I look at who the authors are and decide who I like more. So, for example, if I see a paper by Donna, no matter what position she takes, I agree with it.
That would make it a lot easier.
Yes.
I paid him to say that.
And Julie. Yes. Other thoughts? Yes.
I think it's important to continue to push our field and to drive innovation, and working with local health departments. They like to do what we've always done, but we know that that hasn't moved the outcomes.
Yeah.
So really pushing that, trying things, and then accelerating them.
Yes, great point. If I can summarize, it helps drive innovation and
And the evidence is a powerful tool to bring folks along with you.
yes, it helps bring people along with you. Other thoughts? Yes.
As somebody who's implemented things at the local level, I think oftentimes you'll find that a lot of implementation is based on who's sitting at the table and other factors outside of what you're doing. So I think evidence actually provides some kind of standardization
Yes.
so that we can make sure that, we have all the right steps in place to get the desired outcome.
Yes, I love that point. She was saying she's at the local level, and a lot of times what happens with decisions is dependent on who's at the table. And so this brings a kind of standardization. And I think somebody had their hand up over here.
Just more
Hey,
practical
how are you, buddy?
accreditation.
What?
Accreditation. We have to show when we go as a public health program or department through accreditation, we have to show that we're using evidence.
Yes. Yes. Great point, Lori. She was saying that it helps with public health accreditation. Other thoughts? Did I miss anybody? Did anybody miss me? Okay, let me just answer that too. In our deliberations, when we were putting together the performance measure framework, evidence, why there was such a focus on evidence, because in a way we have 50 to 60 years, almost 100 years of research in maternal and child health. We're the biggest funder of maternal and child health services at both the state, federal, and local levels, and yet a lot of decisions were still being made based on who's sitting at the table. Or, gosh, I ran into somebody at a conference and we thought, that's a really good idea. And we thought, no, let's draw upon all the great work that's been done in the last 100 years. We know we have a good idea what works. Furthermore, when you're sitting at the federal level, you're going to get questions from Congress. Show me how effective it is. Why did you do that? And so to justify the funding for the block grant, sometimes we'll have questions rather than, well, we convened a meeting. Well, that's great. That's an important part of our jobs, to share knowledge, but also, why did you do that? So we're getting more and more of those questions. So we want to change the focus of performance measures. So we introduced a new performance measure framework for the Title V block grant with 3 goals. How many have heard me or someone else talk about this already? Okay, you can tune out. There were 3 goals. One was to reduce burden on the states. There used to be 18 performance measures you had to respond to. We reduced it to 8. Secondly, and another way we reduced it was by that we now provide the data for the national performance measures and the national outcome measures. We also want to provide more flexibility. There are 18 national performance measures. As I said, states only had to choose 8 because what's happening in Minnesota is maybe different than what's happening in Alabama. Okay. And the third level that I'll talk about is state-based or state evidence-based or informed strategy measures. And that's really where you come in, because we want to, rather than get a qualitative narrative back from the states, we wanted some evidence of what you were doing so that we can justify that, so that we can pass that information along to policymakers and decision makers. And so we want, in a way, we're engaging in a nationwide learning laboratory about what can work. And so Julie might find something in Alabama that works, or states that use a certain intervention can work. And so we'll be able to see over the course of years, when states select certain evidence-based measures, what might have worked and what didn't. And so again, I'm going to outshout them in a second, by the way. And so the MCH block grant transformation, again, reinforces the use of evidence. Donna, be gentle.
She's gonna be gentle.
Okay, so to make this work, we want to put as many guardrails in place as possible. We want to help states out on different levels. First, we radically redesigned the National Survey of Children's Health, and we're lucky here to have one of the main managers of that, Jess Jones. And so we now have, instead of data every 4 years, we have data every year, because we want to tie the National Survey of Children's Health much more closely to the national performance measures. And so many measures come out from that. Secondly, as I mentioned, we collect the rest of the data for the national performance measures and the national outcome measures. But there's more than that. How are we going to help the states to work on using evidence-based strategies? And this is where we get to the heart of this workshop. And one of the ways we did it was to fund the Strengthen the Evidence Center. And the first round of that went to Johns Hopkins, headed up by Donna and Cynthia Minkovitz, and worked on with a number of other people like Blair, as well as AMCHP. I always press the wrong button. Okay. So at this point, they've done incredible work. It's been much more intensive than we first thought. They've completed 8 of the 15 evidence reviews, including the National Performance Measure number 5 on safe sleep, and they're currently finalizing work on the remaining national performance measures. And what the evidence reviews do are they summarize all the research based on peer-reviewed and the gray literature. And so what they had to do is come up with a framework. How are we going to assess evidence? And again, this gets more into the heart of it, because now all studies are not created equal. Even all peer-reviewed studies are not created equal. And so they had to assign evidence along a continuum. For a national performance measure that required interventions, it had to be evaluated in 4 more peer-reviewed gray studies or gray literature, or in 3 peer-reviewed studies with expert opinion from gray literature, or 2 peer-reviewed studies, and Tom Brady said it was fine. So, why are we at this workshop? Again, we want to keep emphasizing evidence, but that's not enough for the evidence reviews because new evidence about national performance may emerge based on a single study. So what questions do Title V programs need to consider regarding the validity of this evidence, especially about innovative strategies? And what do they need to consider about adopting the strategy, using new evidence, and the steps in deciding whether or how to implement the strategy? So in this session, as Blair mentioned, we're going to use a case study to discuss these questions. And with that, I will turn it over to Donna.
Thanks, Michael. So we're actually decided to do this case study on NPM 5, which is safe sleep, increase the number of infants placed on their back. And I never actually give up an opportunity to show you my adorable grandson when he was 2 weeks old, and he was very relaxed, and he obviously is enjoying laying on his back. So I thought this was a really nice picture. We decided to do this focusing on the baby box, in part because of a workshop that we did with Michael last year when we were talking about sort of how do you use the evidence from the reviews we did, and we were using safe sleep as one of the examples. And somebody asked us a question about the baby box. And my first response was like a deer in headlights. I had never heard about the baby box. What is this baby box? So we decided to sort of look up what was going on with the baby box. And what I found out was the baby box has been used in Finland for about 75 years, where the Finnish government gives a baby box free to every woman who gives birth in the country. And the baby box also includes a whole variety of other sort of baby resources besides just the box. And the implication has been made that Finland has a lower infant mortality rate than we do, so baby box must be part of that. Well, the question is, what's the evidence regarding that? And it turns out that I think Julie was involved in this. Well, I know you were involved in our technical assistance sort of set of activities from the Centers of Excellence in maternal and child health research practice, or education, research, and practice. And I was involved in sort of workshop number 4, group 4, where we were trying to figure out what could we do for bringing a message of technical assistance to states, which was more sort of a larger group to whom we could bring that message and involve our doctoral students and other students, and really sort of think through what we do well in schools of public health and provide some sort of technical assistance to states. And the decision was made when we were talking about the baby box was, gee, this would be a great example, because is there evidence related to the baby box? And can we think about then how do states actually look at evidence for a new intervention? Well, ironically, there was no evidence, actually, just sort of the time trends and the fact that Finland has been doing this for a number of years. But we learned that there are actually 4 states that are currently, in some form or another, implementing the baby box. And one of them is New Jersey, and I know somebody is here from New Jersey. Another one was Ohio and Texas, and I think all of those are in hospitals, in hospital settings. I think one, Cincinnati Children's Hospital, and Texas, a couple of hospitals. And then in Alabama, so we have one of our colleagues who's going to talk about her story, backstory about the baby box, because this is clearly my backstory. So, as I indicated, there were no published studies. As usual, do a lot of searching on PubMed to try to find research in particular for teaching and evaluations, and of course was involved in strengthening the evidence and going through sort of the whole cadre of studies there. And I discovered that there is actually an intervention in New Zealand that was similar to the baby box, and that in fact was really culturally appropriate for the Maori in New Zealand, and there was some evidence related to that intervention. So it became a great sort of thinking tool for how do we look at new evidence. We have this baby box, we have something akin to it in another culture with it, which has actually been evaluated. Let's use it as a case study. So that's how we got here. And I think Yes, and I think we're ready to turn it over to Julie because she's going to tell you her very interesting story about how she found out about the baby box as well in Alabama.
Good morning, everyone. It's good to see you all. I'm here to tell a story. So, first of all, are there any, we talked about, I know somebody from New Jersey is here. What about Ohio and Texas? Are there Ohio, Texas friends here? Okay, so just New Jersey. How about Alabama? Any of my Alabama colleagues have arrived? Okay. Well, so just a little bit of a backstory. So I'm not with the Alabama Department of Public Health. I might play one on TV sometimes, but not today. So I am with the University of Alabama at Birmingham School of Public Health, but I cut my teeth in Title V, actually. I grew up, I'm an occupational therapist, worked in children's hospitals all my early life with kids with disabilities and other special health care needs. And so where I really learned to do what you do is working with Alabama's Children with Special Health Care Needs program. So for me, making the move over into academic world has been an interesting shift because I always understand and think about the policies and the political piece. So my role in the school, we are all a little bit different. Donna mentioned to you that we represent the Maternal and Child Health Centers of Excellence. So there are 13 programs around the nation that are funded to really do certainly education for students, but also continuing education and technical assistance to our Title V and other maternal and child health related partners. So that's been my role at the School of Public Health in Birmingham. We do, especially for myself, lots of work with community agencies, Title V and others, to help them evaluate what they do. We do a lot of work with needs assessment, and that's really my niche of bread and butter of how do we understand more about what you're doing. Are you doing the right things? And even more so, are you doing them in the right way? Are you getting the outcomes that you thought you would? If not, why? And if so, are you really sure that it has to do with what you did other than because the Patriots lost? Woo-hoo. Yeah. Sorry. So, at any rate, I teach program evaluation, and that's a little bit about how this story starts. But I will ask you, I heard about Baby Box actually because I have a thing for royalty and royals. It's such a cool thing. And so when Kate and William married and we had little Prince George, I don't know if you remember, but actually Finland delivered a baby box. That was one of the, the whole world delivered gifts to this new royal. And I just remember that this cardboard box went to the palace or whatever, and here's the future king of England, and he's getting a cardboard box. And I thought, wow, okay, that's bold. So I don't know if you realize, how many of you really, do you know what baby box is? Have you seen one, most of you? Okay, so it really is a cardboard box. But you think about Finland, and you think about the differences that are probably there culturally, sociodemographically, the access to care kind of issues, the kind of health care environment, plus there are things in the box. It's not about just this box. I mean, certainly there's a cardboard box and there's a firm mattress in it, but also they put a good deal of literature in there and other supports for a young family. Also think about culturally how long maybe women and fathers as well can stay home with infants in a country like that. So it's a very different environment that we know about in the first place. So we also know that the baby box is primarily an intervention for birth to 3 months. It's really for that youngest, very new infant. It's really the best, even though we know there's not really any evidence, but Baby Box is made by a company, a for-profit company that, at least they have good intentions. They're trying to provide safe sleeping environments for young children, but remember that it is a business, okay? So let me give you a little bit of context about infant mortality and sleep-related death in Alabama, and maybe give you a little bit of an idea of how Baby Box arrived. So you can see here our trends for infant mortality in Alabama from 2007 to 2017. So over the last 10 years, we've bumped around some, but we've pretty much been at the bottom of the barrel. So if you look here, the top line, which has the diamonds that you see, that's our Black and other infant mortality rate. And if you see the triangles here at the bottom, that's our Alabama white infant mortality rate. So we're not that different, I imagine, than your states, that we all have a fairly significant disparity in infant mortality between Black and white especially. And in Alabama, we tend to do Black, white, and other, and then sometimes lump Black and other together because the outcomes are similar. But as you can see, there's, over time, sorry, hope I'm not making anybody sick with that. Is it too early for this? Disco? No. Oh. So at any rate, we were anywhere from 2.5 to 3 times more Black infants die in the first year of life in Alabama compared to white experience. The other thing that we know is even, unfortunately, in 2016, we had a tick up again. So our combined infant mortality rate in Alabama for 2016 was 9.1. And unfortunately, that places us at 49th. Okay, we've kind of gotten used to being at the bottom, except for we talk about football, and that's a whole other story. Up the road in Tuscaloosa, not my university. My university football was killed and brought back, so that's a whole other, we can chat the break on that if you care. But at any rate, so we clearly have an issue with infant mortality, and our previous governor and current governor certainly was interested in this for good reasons, as well as we just stink. We stink at this. The other piece is to think about sleep-related death and how much of our infant mortality is accounted for due, or maybe associated with, due to, depending on who you talk to, sleep-related death in Alabama. So you may wonder why I'm standing here and not the folks from the health department. So we do have a fantastic working relationship with our health department and our Title V AMCHP program. Unfortunately, their travel arrangements were set before mine were, so they weren't able to join us up here, but I just want to assure you that, we're all on board. They shared these slides with me. We talked through what I would say today. I'm very sensitive to the politics and the policy and the understanding. So you'll see them. So I certainly am remiss already for not having credited them earlier. If you know Chris Haig is the Title V director for Alabama. He'll be here, I think, either this afternoon or first thing in the morning. Janice Smiley and Amy Stratton, and they are very involved with perinatal work in Alabama, and specifically the infant mortality in general. So those individuals shared these slides, and they're on board with what we're talking about today. So the sleep-related death, I've been to many meetings, and you'll hear Chris Haig talk about if we could just address sleep-related deaths, we would really impact infant mortality in Alabama and put us closer to national averages. Sort of been the mantra along that sleep-related death, there's some, behind every number there's a story, behind every number there's a child in a family. And so we drill that in with our students, but I know you know this as well. I mean, numbers need someone to champion them and to put a face for that. And so Chris Haig talks a lot about the father who, was working the 2 jobs and came home and had the baby on his chest, fell asleep in the recliner and woke up with the baby, had smothered and died. We all have those stories like that. So not only do we understand about the terrible feelings of guilt and that could go along with there, and could we have prevented that? But sleep-related is also, we think, somewhat of a low-hanging fruit. So the epidemiologists in Alabama have calculated that about 21.4% of the total infant mortality is because of a sleep-related death. So you can see why it would make sense to think about sleep-related approaches, and that this is clearly an evidence of need to address sleep-related death in Alabama. The other thing is we understand that SIDS, or SIDS or SUID, but from their materials they call it SIDS, is the 3rd leading cause of infant mortality in Alabama. So the first one, as you might imagine, and I'm sure it's similar in your states, is congenital anomaly. And those are things that you may or may not be able to prevent. Those are things that happen. They're usually first day of life, first week of life, certainly first month of life loss, a lot of death from that. But also prematurity, which is such a tough nut that we've all, we deal with that. But number 3 is sleep-related. So you can understand, again, why this might be a target or a focus area. thinking about it's not the top or the second, but it's the third most common cause of infant mortality in Alabama, and theoretically, we might be able to do some things to prevent it. So it makes sense that this would be a focus area for the state, even in addition to the national performance measure that would tell us we need to think about that. Also, from our data and our epidemiological look back, we understand that, and this is important, that the percentages of infant sleep-related death among infants in Alabama were higher for our full-term normal birth weight infants, so not as much in the prematurity area, so the full term, higher among Black and other race families and infants, and younger mothers with lower education levels. So again, thinking back to what we know about Finland and where the idea of the baby box originated, where it's been around and using that, those are some different individuals. So, you know, already we know that things are different. The infant mortality is clearly one of the lowest in the world. They probably don't look like the mothers that we know are at highest risk in Alabama. So that's the first sort of a red flag, but, you know, it doesn't mean that it's not appropriate. It's just there are already some differences, and sometimes when we take policies from one place and apply them to another, which is a great shortcut, I mean, sometimes that's great. If we know something works, why not try it? But this would be a little bit of a flag that we would wonder about. And then finally, these are the last data that I'll show. These are the last data that I'll share, and then we'll talk about a story. You can see these are sleep-related deaths by infant age. And if I'll just draw your attention to these set of bars here, you can see that the pink is from 2011, the purple here in the middle is 2012, and then the blue here on the side would be from 2013. But the big piece for you to take home certainly is that this, oopsie, fun. The big piece to take home is that this is the 1 to 3 month old infant. So about half of our infant deaths happen in that age range in Alabama. So the risk factors are different. And the risk factors for these young infants have to do with not being on a safe sleeping surface. So again, now you're hearing a little bit more about baby box, right? I told you when we first started that baby box is a birth to 3 month old intervention, right? To provide a safe sleeping surface. So for our older infants, we see that death is more associated with things being in the surface. You know, the blankets, the crib bumpers, the teddy bear. You know, or somebody rolling over, it's really not as much. But for these youngest infants, it's more about that actual bed sharing and the surface itself. So, again, about half of our death are in the range that theoretically could be addressed with a baby box, cardboard box. Okay, now we're to the story part. This is a fun part. So, stop me if you've heard this before. A man walks into a meeting. Yeah, okay. So in Alabama, our previous governor, Dr. Robert Bentley, I know you probably have heard a few things about him over time. He's not our governor right now for things that I shouldn't discuss since we're being recorded. However, Dr. Bentley was indeed a physician, a dermatologist from a rural county in Alabama, had a special place in his heart related to rural health, put a good deal of money into policies and programs, not only about health, but education for children and economic development in rural parts of Alabama. Alabama is it's a very heavily rural state. We have some population centers, and even in those population centers within the county, you don't have to go far and you're back out in rural area. So we really do have an issue with rurality and disparity as well. So there was important point, was an Office of Rural Health and Development under Dr. Bentley. And an individual who had been a very key political ally with Dr. Bentley was placed over that agency, had been into politics, had been over the state agriculture department, but you're not hearing health, right? Okay, so this individual, though, attended some of these same meetings where they saw these staggering infant mortality numbers, where for years we talked about being, we would celebrate being 48th. 40, now we're 49. We see these staggering and just heartstring tugging losses and the personal stories, and then understanding about sleep-related death. So, you hear that of, gosh, if we could just address sleep-related death, we could potentially come more in line with national averages. So this gentleman heard this and was equipped with this, and being a good person who thinks about dot connecting, was in another meeting somewhere, out of state, I'm not sure exactly the story, but learned about the Baby Box program. So the Baby Box heard this is an intervention. I'm not really sure the details on where he heard, but it was outside of the health department and the state. So he contacted Baby Box and said, I'm so-and-so, I'm with this, I think this might be a really good intervention in our rural counties. And of course, Baby Box, well-meaning, clearly interested in reducing sleep death, also interested in, they have a product to sell, right? They're a business, and they connect to other products that sell to parents. So Baby Box said, we'd love to work with you. Baby Box says, we would love to do this. As a matter of fact, we'll give you boxes for free. We'll give you 60,000 boxes for free. And we'll even support you to develop whatever kind of educational outreach that you'd like to do. So a lot of money, right? So the individual came back and said, what do we always do in state government when you come back in all this? What was the first thing that we do? Convene a meeting, right? Convene a meeting, create a task force. So pulled in, now you have health at the table. Now health department is at the table, other individuals that work with children and young families. So really a good job of pulling people around a table. It didn't start in the health department, started in a whole other arena, but now an opportunity came, hey, Baby Box wants to come, we're gonna give you 60,000 things, it's for free, and by the way. So there was an opportunity that didn't exactly come through the right door, if there is such thing as a right door, but it didn't originate in a way that somebody thought about the traditional, we have this issue, we know we have an issue, let's think about the evidence, how might we address this problem? So it was sort of an opportunity that came from a pretty powerful political person in the state. So I know that you've all been in situations like that, and so there's a delicate handle when those kinds of things happen. You don't want to, as a matter of fact, I was talking to my colleague at the health department about this, the classic quote that I wanted to put in there, and of course now I'm going to tell you anyway, but is, who's going to say no to free? I mean, really. I mean, you do this, you live and you do this work every day. So that's the politics and the partnership that came there, and so the really cool thing is that there was a recognition of bringing people together to talk about that, hey, I went out and found this opportunity, but I know that other people need to be at the table. Well, so then as things were beginning to come along, we understood that there were some changes that happened in our state government. Our former governor resigned, and the lieutenant governor took over. She was very committed to making changes in state government in Alabama. She removed and replaced probably 3/4 of the appointed positions, maybe more, that were people who were in charge of or over agencies, and she actually dissolved the Office of Rural Health and Development. It's gone. So this was kind of in the nascency of this program, and then we had a really big political change. But Baby Box was already coming, so I was preparing for this, and I guess I had missed some of it, so when I was Googling just to see what was out there in the news related to it. So there were lots of press releases when this happened last March, lots of press releases about Baby Box is not going anywhere, it's going to find a home, we're not going to get rid of it, it's, all this, and then the statistics about infant mortality and sleep-related death in Alabama. So a lot of political wrangling, machinations, let's just make sure that we know that, hey, we're not doing away with this part. So about this time, here's the other part. This is probably the part you haven't heard. A professor's listening to NPR on the way to work. Right? So I told you that I teach program evaluation, and it happened to be that it was a morning that I had class, and I was driving in. It was during the class that I teach, and I heard about this program, and hey, it's in Alabama, and this is the first I'd heard of it. I try to stay connected, but it's really funny that you hear about this big initiative and all this stuff, and I hear it on NPR on my way to work. And so I brought it up in class. We were talking about all these issues related to program evaluation, and some of my students had done a little looking, and then as students are wont to do, they continue to look in the middle of class because they do their own thing. But I was just happy they were doing that, not Facebook or Instagram or whatever. Yeah. so they were looking at Baby Box and what was out there and some of the training videos. So we had this whole class that basically shifted into, I wonder if they're thinking about evaluation of this. I wonder what kind of evidence they had in the beginning to bring. I mean, it came. I didn't know the politics behind it at this point, but we wondered a lot. Well, how would we know? And if it worked, so it worked in Finland, but will it work in Alabama, in rural Alabama, and with the racial, ethnic, socio-demographic makeup? You know, and if it doesn't, will we know that? I mean, the obvious outcome measure has to do with sleep-related death. But what about all those process and implementation and understanding about the education and the uptake? And, well, what if one group of individuals will uptake and others don't? Or just because you got a box, does that mean that you used it to store extra diapers in? Or are you really using it for what it's intended? And if you are you doing it every time the baby sleeps or just once in a blue moon? I mean, those kind of questions that you all would care about, right? So that you know if it works, woohoo! But why? And if it didn't, are there things that you might tweak so that maybe certain individuals need different kinds of education, right? So we had this great discussion. So of course this, triggers me to go back and talk to my colleague that we do a lot of work with them and say, let's offer to do it. Let's offer to do it for free. Let's do it as part of our outreach for the Center of Excellence. We need to be in this. We need to be involved in this. So that's when we find out about all of the goings on and everything was changing, and we actually offered to run the program for them so that it would not. So where we are today in Alabama, it didn't come to UAB, it didn't stay in the health department. The governor designated the Department of Human Resources to be the lead agency for Baby Box in Alabama. So it's outside health. That is similar to if you have it's the child abuse and neglect prevention. So it's kind of an interesting place to put it. It's not related to any kind of health interventions or anything like that. We don't know a whole lot about what's happening with evaluation for it, other than Baby Box collects data, but we don't really know what. I understand that a lot of it has to do with mailing lists and things to collect who gets the boxes so that you can mail out other products that young families might be interested in. And what I learned from my colleagues is that in actuality, even though there's a pretty big need for that birth to 3, we see that half our infant deaths, our health department actually would not have selected and they didn't particularly want to be the lead agency because they felt like that this would be really they wanted to think about strategies that were throughout the entirety of that first year of life. They really wanted to think about approaches that would be something that a family could use for an entire year. So they're asking the right questions that I'm sure you would. Now, this was free, but if you had to buy them, and I don't know how much they cost, but you have something that can be used for birth to 3 months, would we be better stewards of Title V dollars if we bought cribs or pack-and-plays instead? We don't know. We don't know the answer to that. So the idea was, how can we be involved and think about some of those other levels on the pyramid, the old pyramid about what level of activity. It's not always about creating a direct program, right? So they saw this as an excellent opportunity to create public awareness about safe sleep in Alabama, raise awareness. And there was already a lot of numbers, and here's this big thing, and it's very splashy. So this is a great opportunity to raise public awareness about sleep death. And this was an excellent opportunity because Baby Box offered to fund the development of new training materials and videos and such. Health department said this is a great place for us to fit in to assure the quality of that and to assure the accuracy of that. So it was a great opportunity to partner around public awareness and around education, more of a population kind of based approach. So they're not the ones who are delivering the boxes, right? They're not the ones who are running the program, administering it, but in these kind of partnership roles to think about, and also so being really integrally involved in the development of these videos, using Alabama-based physicians to deliver so that people see people who look like them delivering the education. Okay, so you're getting at some of those cultural competence issues that are so incredibly important then to the work that we do, and you know this. So the idea in Alabama is that the Baby Box is just part of a strategy. It's part of the strategy that the Title V MCH program would think about because, again, they're interested in the whole first year of life. Baby Box is not something that they're doing in their own offices, but it is in reality, what they do then on the backside is using those Title V dollars to connect those families. So after 3 months goes by, and there are families who continue to need support to identify and or fund a safe sleep environment, well, they can then come on the backside and purchase that pack and play crib kind of program. So that's the commitment is, okay, well, we'll overlay this intervention and stay very integrally connected and interrelated, right? So, maybe this wasn't exactly the story of the health department deciding that. This when Donna asked me to come, I said, well, there's really a story here. It's more about politics, and is this what you want to talk about? But I suspect that this sounds a lot like what you all face sometimes. That sometimes you inherit things that you didn't go out and find. And you have to figure out how to make that work and how to bring science and public health and accountability to bear. And I think that's one of the neat things that happened in Alabama. We clearly have a need. There's a clear indication that something needs to be done. So there's no one arguing that. And again, I don't want to put any more words into their mouth than what they've told me to share. So I'll try to restrain myself. But I think that this really highlights what it is to do the dance sometimes of trying to marry the evidence with, you get some really interested people that have some political power. And so Baby Box is going along. We continue from the School of Public Health to say, hey, if there's an opportunity, we'd love to work with you on evaluation to think about some of those like nitty-gritty things in the middle so that we can know more. We can know more about beyond just the numbers. Can we understand what's really happening at a local level and within different groups of individuals? So I guess the jury's out. And I don't really know what else I might say about that at this point, other than, NPR and people going to meetings, right? And an idea is born, so. I'm going to turn it back over, right? And then we can, are there any specific questions? I know we're about to be on a break, is that right?
No, actually, we're ahead of time. So
We're ahead of time? Okay.
yeah, so I'm actually going to try to introduce the basic concepts, and then we'll break.
Fabulous. Are there any just burning, yes ma'am, is that okay if I ask?
Yeah, sure.
So are there any next steps for evaluating?
So I don't know if you heard,
Or are they just going to look at the data next year?
So she asked about evaluation. She said, are there any next steps? There are none that I know of. That doesn't mean that they don't exist. I work more with the health department and early childhood education departments in Alabama, not the human resources. So there could be. I know we've talked a little bit with health department about what they will do on their side. My colleague and I were talking about, could we add a question to PRAMS? Could we talk about, and I'm really keen to talk to some of the other states. I'd love to talk to you guys in New Jersey about what you're doing. Are there some ways we can get at, did you get a baby box? Because, if you can't, even if we just look at these aggregate numbers, we won't know. If it changes, we really don't know. So how could we get a comparison and a control? So we've been talking a little bit about possibilities, but I don't know that there's nothing formal that I know of. Yes?
Can you talk about the logistics of the last bullet where you assess how they continue to need support? Is the public health department getting names? Are they surveying? How do you assess needing support and getting them that grid?
So just for you guys in the back, so Kathy here from Alaska. Wow, you're up early. Yikes. So, and I'm looking at you because you have a twin, a good friend of mine. You have a sister, but anyway, that's a whole other story. She wants to know about how the health department is assessing this need. And the answer is, I don't know that part. I really don't. They tell me that they're doing that. I know that they are. That would be a question I'd have to, if you really want to know, I'll take your number, or name and number, and we'll get you back, or connect you with Janice. But there is clearly something that's happening with that because they are committing dollars to do it. I think I saw, yes, sir.
And I'm open to this being answered later. This is more of a kind of a technical question, but I'm wondering, how do you assess the difference between the contribution that the box as a sleeping environment makes to increasing infant mortality versus what normally are a lot of resources and intervention that occurs along with the box? So it's not just, here goes the cardboard box, and all of a sudden infant mortality is lower.
Right.
So how do you, is it important to separate that out in your opinion as a program evaluator? How do you do that?
Oh, yeah. So Delmar has asked the question about how would you, I'm going to put it in my words here a little bit, if that's all right, about is it important to, and would you want to, I guess, identify which piece, how much of this, if you do see a change, how much of it is due to the baby box itself versus all the other pieces that go along with that, and absolutely. And I think I'm gonna punt a little bit because we're gonna talk about that as the session moves along, but you clearly would want to do that. Because there may be pieces that it's not, is it really just the fact that you plopped a cardboard box in there, or is it all these other resources that are around? Is it what's in the cardboard box? Is it the education? There's so many pieces of that. So, and as a program evaluator, it's hard to do that, you know, in a lot of ways, because there are things we can control and things that we can't. You try to have those rigorous research designs of control and cases and things like, but you know, it's not a randomized control trial. Certainly not happening in Alabama now. So.
It just occurs to me that the box itself is getting all of the publicity, when
right.
it very well may be the intervention that is causing the decrease that we're seeing.
It's right. And, you know, we do, again, I'm going to punt back to her, but there are some things that we do with, you know, in evaluating policy changes and sort of time one, time two, and there's some statistical things that our economists work with us to account for what else might we know about state policies, things that we can't really put our, you know, economists are great at making assumptions, and they have fancy little things that they do that you can just make a variable for it and go, oh, well, that took care of that. So, yeah, but you're right onto it, very important. One more? Yes, ma'am? Or two more? Okay. I'm sorry.
Curious as to what is the criteria for people getting their box? And also, where are they being distributed? Are they distributed to the hospitals? Or?
That's a good question. And like I said, there are 60,000 boxes. They're free to anyone who really wants one. In order to get one, you have to complete a training video. There's some training pieces that you have to do. So you can't get one unless you do these pieces. Many places in the state have signed up to be distribution centers. A lot of it does happen through, I told you it was the Department of Human Resources, so a lot of folks that might be connected with that agency, and you would, low resource kind of families, but they wouldn't, I don't think, turn anyone away if you wanted one and you really couldn't get one in terms of the box itself. But many distribution centers, hospitals are some, these departments of human resources or others, various and sundry places. I know that there's a little bit of a, maybe get to a little bit of a technical issue here, but I was talking to my colleague at the health department. They were trying to be a distribution center, but there's some issues that, because of the way Baby Box tracks, there's some question about HIPAA compliance, and that, you know, they were trying to have kiosks in their health departments in all 67, we have 67 counties, and each county has a health department, and so that you could go there and access the internet, take the training, and get your box, but it stores information, and so the worry is, you know, are you really protecting identity and privacy and such like that? So there's some logistics that have been difficult, I think, but right, it is varied across the state about where you get one. So one last one, and then we'll, and then.
In terms of evaluating for the actual utilization of the Baby Box, do you have any information about the cultural acceptability?
Exactly. I mean, you're right on, and we don't. And that was kind of where we were headed with. There are many other questions to answer besides, do we see a change in sleep-related death? You know, we don't know about cultural acceptability. I was telling Donna, and I was so hoping somebody might ask this so I could bring up a little story. You know, everybody's different in what they accept and what they don't. We were involved in the most recent Title V needs assessment, and we were talking about sleep-related safe sleep guidelines in a survey, but also in a series of focus groups that I did around the state. And we really made some people mad. I don't know how it happened, but you know, maybe perhaps it was just I don't know, you got into a nest of people who just disagreed, but we provided the safe sleep guidelines, and we were trying to elicit why people thought those might be a challenge to implement. And we got everything from, I don't know who you are, how could you, you know, that's not what my person told me, that's not what my grandmother did, and I do this, and who are you to tell me? We got everything from that to, you know, less vitriolic, but still very, and the kinds of differences were it was amazing. I mean, the differences, it really wasn't with any one particular group. And a lot of the things that we assume, and we say, well, culturally, these groups of people don't do this. Well, that's not, I mean, again, not what we really found when we looked at survey responses and going into focus groups. And, you know, we had a nice series of focus groups that ended up being in somebody recruited all from a La Leche program. And it was a bunch of nice, crunchy granola girls, and you know, lots of breastfeeding going on, lots of babies in the floor, and they were really opposed to some of the safe sleep guidelines. So you're right. It's very, and we don't know. We don't know. Yeah, I'll let that part out. It's being recorded. She knows. She knows the other part, but talk to me at break. So, but these are absolute, and you would need to know this. If you had to pay for it, if you were going to dedicate your dollars to this as opposed to something else, these are things you'd want to know, right? Okay, I didn't mean to disenfranchise your table. I saw. Oh, okay. All right. Okay. Yep. I'm going to pass it back, and if there are more, we'll chat at break or later, okay?
So we are a little bit ahead of schedule, so I thought we'd move to the next sort of very short set of slides. Sort of interestingly, if you want to buy the baby box retail, I can tell you because I Google a lot of the sort of baby box sort of resources, and the retail cost of the baby box is $500. Now, I suspect that if you're selling them in bulk to a health department, it's less than that, but given that a pack and play is a couple $100, or it's a pack and play, right? I still remember. I try to remember that I had one of them in my house for my grandson. But given that that's a couple $100 less in cost, sort of an interesting question about sort of the baby box and the company promoting it in sense of giving you free baby boxes to start you off. So what I'm going to turn to now is thinking a little bit about sort of what do we think about when we think about the new evidence before we actually go to the study. And I was delighted to see that some of you actually had the study printed out and you read it, but I'm still going to go through it after the break. But what I wanted to talk about first of all were some key concepts in evaluating the scientific literature. And in particular, the counterfactual, which leads us into thinking about forms of validity. And validity of inference particularly, because what we want to do when we're looking at new evidence is to think about what kind of inferences can we draw from that evidence. So can anybody tell me, how many of you have heard about the counterfactual? Oh, not very many of you. So do any of you want to tell me what it is? Jessica, you don't. She's one of our doctoral students. She knows what it is, right? No. Anybody want to tell me what it is? Fiona, do you want to? Sure. Fiona was one of our master's students who's now in
Wisconsin. Yes. Well, the counterfactual is basically, well, in methods, it's an approximation of if, this person had had a different experience, essentially. So intervention or not, exposure or not. And you approximate that with different kinds of experimental methods.
Good job. Good job. She learned something from the course she took with me. Okay. So what do we mean by the counterfactual? It's something that's contrary to fact. So we never can observe it. And this is where it becomes sort of, it's very abstract. In fact, I teach a course with, on clinical aspects of maternal and newborn health with my colleague who's a physician's assistant in the NICU, and when I first introduced this to some discussion of a paper we have students write on looking at the scientific evidence on an intervention, she said, I don't get this. I don't get this. It just doesn't resonate for me. It took a while, and now she gets it. So it takes a while to sort of think about this because it really is very much an abstract concept. But in an experiment, we observe what happens to someone who receives the treatment. So, very clear. And the counterfactual is, what would have happened if the exact same people didn't get the treatment? So when Fiona said it's both an intervention and an exposure, it is both. It is both. But it's really sort of, we can't tell what would have happened. So what we're going to have to do is think about sort of what we need to do in designing studies to get as close to that counterfactual as we possibly can. So the effect is actually what happened, and it's the difference between what actually happened and what would have happened. Okay, so we have to construct this counterfactual. When we look at studies, we're always looking to see the extent to which the investigators actually create as close to a perfect counterfactual as you can get. And that's part of what we're going to be discussing later on about this particular study. we can never observe the counterfactual. But in the counterfactual, we want to have a control group that behaves well. We don't want one that looks like this. And this one's really out of control. I've got another slide where they're just sort of a little loosey-goosey. But we definitely don't want a control group like that. That's a bad counterfactual. So when we think about then the counterfactual, where do we, from a standpoint of being able to look at a causal link, and I'm going to talk about internal validity because this is where sort of the causal link comes in, is, so what are the best designs? Well, K-series, nah, we don't have a control at all. And then we have observational studies with a comparison, but there we've got a major problem because people might have sort of decided to take the baby box for a variety, for this example, for a variety of reasons that have to do more with their personal characteristics than necessarily the baby box per se. So we have some problems there, even if we had a control of individuals who didn't get the baby box. And then we have quasi-experimental designs, and basically those are designs where they're experimental, and there's some really nice ones, like if we have pre-test, post-test for 2 different groups, and we can observe what happens over time. The problem with quasi-experimental designs is that you don't have control over who actually gets the intervention. So we go to the next level then, which is a randomized controlled trial, and here what we do is actually assign people randomly to the intervention. And what we try to do there is to assure that at least the differences between our groups are in fact due to random error rather than some kind of selective bias. And bias meaning that it's systematic in some way. So what do we really want to know then when we're looking at a study? Well, first of all, we want to know about internal validity. Does, in fact, X actually cause Y? And can we actually be confident that the observed variation between X and Y actually reflects a causal relationship between the two in the form in which the variables are manipulated? Okay? Everybody okay with me there? Anybody have a question? Okay. External validity is a little more interesting because when we talk about external validity, our knee-jerk reaction is, well, is it representative of the population? What population? So really, external validity is about the validity of inference, about if the cause and effect relation holds over variation in people, settings, treatment, and measurement variables. So it's not just about whether or not our sample is generalizability, but it's really about, are our methods generalizable, and is our treatment generalizable? And there's this whole issue when we come to statistical validity is to whether or not we have messiness in our treatment and how we implement it. It's not standardized in some way. So validity of statistical validity is really the validity of inference about the covariation between the intervention and the outcome. It gets fairly simplified when we're talking about sort of randomized control trials, and we can raise this a little bit if you want to talk about the study for the baby box, the baby basket. I can't say that word. Anybody know how to pronounce the word? Kahakuro? I don't know, but anyway, I'm going to call it the baby basket. It's just the easiest way for me to talk about it. So what are threats to validity? So threats to validity occur in all of these domains, and they're really the reasons why we may be wrong about an inference related to covariation, causation, measurement, and generalization. So before I go there, I just want to sort of comment a little bit about, I'm not going back? Oh, I went way back. No, I was fine. Yeah, I know, let me get the bed ready. Why is it not going back? There we go. Okay, all right, good. So now I think I just had a senior moment, forgot what I was going to say. So maybe what I'll do is take questions and see if I can remember. Anybody have a question so far about what I said? Okay, so I guess really what I'm sort of want you to think about when we move to the study, and we're going to break now. It's probably a good time to break. We're on time now to break? Right, great. So when we think about it, I'm going to give you information on the study for those of you who didn't have the opportunity to read it. And probably like me, you were very busy this week, and I actually got a chance to go back and read it again since I read it a while ago. But if you didn't get a chance, I'm going to give you the opportunity, I'm going to give you the information that's really critical in sort of thinking about the performance measure that we're evaluating. But when you're doing it, and we're going to break up in groups after I describe it, but when you're thinking about sort of what kinds of inferences can we draw from this particular study, it's not just about whether or not the baby box makes a difference, but it's also about the extent to which we think about to whom can we sort of infer these findings? Are they sort of, can we make inferences across settings and to other individuals? And did they do a good job in sort of ruling out, that's where I was going, ruling out the probability that in fact we have differences between our intervention and control groups in such a way that they may have explained the differences, and sort of how do we think about that variation, or how we think about what we're missing there and that probability. And when we're creating the counterfactual, we're trying to reduce that probability. What's particularly important when we think about a study related to the counterfactual is the extent to which we understand how it is imperfect, and the extent to which the probability that given it's imperfect, that we're actually not making an accurate inference about the findings. Okay? So we're going to break here, and then we're going to come back and talk about the Braddock study, and then we're going to let you break up into groups and think about, well, all right, what is it that we think is really important in looking at this study? What kinds of questions do you think we should be asking? And to discuss that among your group, and then to really think a little bit more about how well they actually sort of address the questions that you think are important to ask about a study. So thank you, and we'll be back in about 15 minutes.